Well, thank you very much. I have a bit of echo here, and it'll be fine for me, but please let me know if you don't hear me well, and I'll do what I can to fix it. I do apologize for not being there in the room today. I would love to be able to talk with everybody in person, but we did have some mechanical failures this morning, so we'll do the best that we can, and let's get started. So if we could go to the next slide on U.S. infectious disease mortality rate, I want to step back from obesity for just a moment to help give a little perspective on where policies and structural changes fit in to this whole epidemic. So if we go back a century ago, infectious diseases like tuberculosis and influenza were by far the greatest causes of death in the United States. Except for that blip in 1918 for the flu pandemic, infectious disease rates then plummeted over the first half of the 20th century. There was about an 80% decrease in infectious disease deaths in just 4 or 4.5 decades, as you can see there. Now, most people tend to think that this improvement was due to really good antibiotics and vaccines and such. And while you'll see that is a part of the story, actually we didn't have most of our really helpful, important, high-tech antibiotics and vaccines until the mid-century or the second half of the century. The vast majority of this decrease in infectious disease mortality over the first half of the 20th century was due to policy and structural changes that led to safer foods, clean water, decreased overcrowding in cities, and similar environmental changes that made it a little bit easier to be healthy in our society back then, and perhaps a little less easy to be unhealthy back then. Now, that was in the first half of the 20th century. Then if you look, and it's hard to see in this graph, but if you look from the mid-40s to the rest of the century, that second half of the 20th century, we saw virtually another 80% decrease in death rates from infectious diseases. And that was in part continuing accruing benefits of these policies and structural changes that occurred in the first half of the 20th century, but it was especially because we then tied those policy and structural changes to improved treatments and interventions, things like antibiotics, like penicillin, and vaccines, and policies to mandate those vaccines, and supportive treatments and such. And so you put those two things together, the big picture stuff, the policies, the structural changes, the environmental changes, along with the specific clinical treatments for those that are affected, even despite the changes in the environment. And as you see, we can make an incredible difference in how people live and in how long and how well they live. So this is a really important example of a public health epidemic that we've made incredible strides from. If we could go to the next slide now, I want to just step back from obesity for just another moment. Now we're looking at the curve of tobacco use in the U.S. over the course of the 20th century. If you look at the first half of the 20th century, there's an increase that very much parallels the epidemic increase in obesity over the past several decades. Rates just kept going up and up and up. By the 1940s and 1950s, we had a number of very good studies that proved that tobacco was unhealthy. It caused lung cancer, heart problems, and so forth. And parents began telling kids that they should try not to smoke because it's unhealthy. And teachers started teaching their students the same. And doctors started teaching their patients the same. And yet, with all that education and the knowledge of how unhealthy smoking was, rates of smoking actually continued to go up for several decades. We even had the first Surgeon General report by former Surgeon General Luther Terry, I believe in 1961 or 62. And so that codified these teachings for the whole country. And yet rates of smoking didn't go down as a result of those things. Now, if you could click once, there should be two little boxes that pop up that show some of the policy and structural changes that we then put in place over the course of the next few decades in the 70s and 80s. One example is an broadcast ad ban on tobacco marketing on TV and soon thereafter in radio and billboards. Another example is an increase in the federal cigarette tax, and there were a number of others. And as you can see, when we put the education and training together with environmental changes and policies and structural changes together, those things can make a big difference. And we see that rates of tobacco use started going down pretty significantly. And then if you could click again, please, then you see that come the 1990s and 2000s, we then, on top of those policies and structural changes and education, we also intervened in appropriate people with treatments for tobacco addiction. So nicotine replacement therapies, there are a few FDA-approved medications that can be extremely helpful for certain patients, improved counseling techniques, quit lines, and so forth. So we were giving people who are already affected access to treatments. And rates from tobacco continued then to go down. The rates of tobacco use today is about half what it was just a half century ago. So we've made incredible progress, as you all know, in that area. And it's because of this combination of the top-down pieces, policies, structural interventions and such, and bottom-up pieces, education and treatment for those who are already affected. Next slide, please. And I just threw in one more slide here because we're talking on the local level and the state levels. Here's what happened in New York City. Even after that significant improvement nationally in smoking rates, for about a decade heading into Mayor Bloomberg's term in office in New York City, the rates of smoking in New York City was a flat line. They weren't going down anymore. And that was one of the primary priorities that Mayor Bloomberg and former Health Commissioner Tom Frieden put into place in New York City, was to address the smoking epidemic that was still there. And as you can see, within just a few years, rates went down by an incredible amount, down from the 21.5% to 19-18, eventually down into the 16% range of smoking rates. And the way that it happened, very similarly to my two last examples, was top-down and bottom-up approaches. On the one hand, there was education efforts, there was awareness campaigns, media campaigns, and there were improved treatments, including they gave out free nicotine patches to a large number of New Yorkers who needed them, including improved counseling, including setting up quit lines, combined with regulation, legislation, economic policy changes that change the context in which people live. And these things together made, as you can see, really significant continued decreases in smoking rates. Okay, so next slide, please. So now we get back to obesity. So those principles set the stage for me and my teams in how we approach obesity. This here is the CDC framework for addressing obesity, and it essentially says the same thing that I've been saying in the past few slides. What we have to do is, on the one hand, at the center of that diagram, is to help the individual in order to eat healthier, in order to increase physical activity, and other supportive ways of helping them prevent and treat their obesity. But the individual is couched within so much more. We live in a variety of behavioral settings that can either set the stage for lots of healthy behaviors or set the stage for more unhealthful behaviors. And those are things like the schools that we live in, the workplaces that we go to every day, the communities that we live in, that we play in, and such. And so addressing those behavioral settings is going to be important to set the stage for the individuals to be able to be healthy. And around that are sectors of influence like the food and beverage industry, the agriculture setting, education, media, the government, the healthcare system, and access to healthcare and preventive services, on and so forth. And so then we have social norms and policies, national, state, and local. And those, again, set the stage, as we talked about in the other examples, for what the individual does in terms of various health behaviors, and certainly in terms of the ones that play into obesity rates. So this is the conceptual framework that I suggest you keep in mind and follow as you figure out how to move the needle forward in your state, in your communities, and such. And I want to echo something that the opening speaker mentioned. She said that there's lots of solutions, and I think that's really important. Obesity is a very complex chronic condition, and there is no silver bullet to managing or reversing obesity, not on an individual level and not on a policy level either. We need to keep putting together a number of helpful and supportive policies and treatments that help people improve their health. Next slide, please. So I put here a publication from the CDC from, I believe, 2009 on recommendations for local and state governments for how to prevent and address obesity. And I put there also the website that you can go to so you can look at this in depth. So I won't spend too much time on it, but this is a great example of helpful publications that can help guide your work. If you can go to the next slide, please. They have 24 key strategies as recommendations for local governments. Again, I'm not going to go through it in depth, but I'll just point a few of them out here. The first category of strategies they recommend is strategies to promote availability and affordability of healthy foods, access to supermarkets, incentives to food retailers, and such. Next slide, please. They recommend a set of strategies to support healthy food and beverage choices, essentially trying to get at this concept of how to make the healthier choices just a little bit easier, and perhaps how to make the unhealthy choices just a little bit less easy. They have a strategy to encourage breastfeeding, which we know is associated with lower rates of obesity and other health improvements. Next slide, please. There's strategies to encourage physical activity and limit sedentary activity in children. Strategies to increase the use of and effectiveness of community coalitions and partnerships to address obesity. And next slide, please. Strategies to create safe communities that support increased physical activity. And there's a number of specific recommendations under that one as well. Again, I won't go through it for time, but this is something that you can freely download on CDC's website, and I think it will give you a lot of great guidance in how to navigate the potential policy choices around obesity. And these are all evidence-based recommendations. Next slide, please. I also put in here a link, and I believe one of the speakers I heard mention this as well. There's a link here that you can go to the CDC's Chronic Disease State Policy Tracking System. And this, again, will give you a lot more guidance and possibilities for your policy decisions as you see what other states and localities are working on. Next slide, please. So I put here what is, I think, a really important data from a recent publication that shows that these things can actually work. So this is actually not from the U.S. It's from France. There was what is in a sense a randomized controlled trial there, where there were two towns that had a bevy of interventions put into place to address childhood obesity, and then there were two control towns as well that didn't get those interventions put into place. And we saw some pretty striking things as a result of this intervention. I'll talk a little bit about what it is. First, if you look at the inset graph in the top left, it shows where obesity rates went throughout many countries in the world, including the U.S., which of course rates went straight up in the 80s and 90s and 2000s, and Spain, and in France overall rates were going up. And yet in these two towns, if you look at the right side graph, in those two towns, after beginning these interventions in the early 90s and slowly scaling them up throughout the 90s, rates of childhood obesity started to go down, and pretty significantly so by the turn of the century. The rate in girls in particular decreased from about a high of 18 or 19% down to about 10% as of 2004, and the rate in boys as well came down quite a bit. So this is pretty impressive. And the set of interventions that they put into place was really quite impressive and comprehensive. They worked in schools, they worked in the community, they included family-based interventions all together. They worked with stakeholders in the community, including community associations and businesses, to create healthier options. They trained teachers in nutrition and physical activity so that they could help educate their students. There were school-based changes in the foods that were available, and physical activity opportunities and physical education opportunities. There was a school-based nutrition education program put into place, and soon they took that school-based education program and they translated it to a program that they shared with parents that they could bring home to their homes. There was incentive programs for physical activity. There was family education, as I mentioned, including not only nutrition, but including healthy cooking. There were media campaigns and community campaigns, and I could go on and on. It was a really strategic and effective set of interventions that get at this concept that I keep going back to on the importance of both policy and individual approaches, on the importance of both structural and educational interventions. And they made, as you see in the graph, really an absolutely incredibly impressive progress over the course of just a decade or so. So that's something we can hold up as something to aim for as we continue to move forward on our childhood and adult obesity epidemics in this country. Next slide, please. So mostly I've talked here about broader level interventions, policy and structural interventions that are important. And I keep mentioning the importance of individual level interventions and treatments as well. By all means, prevention and setting the stage for healthy behaviors is absolutely essential at the core of this. But we're already well into this pandemic, in fact. And for those people who are already affected by obesity and obesity-related chronic diseases, we we need to help them with treatments, just as we would for any other health condition for people who are already affected. So that's the other side of the coin of prevention. They go hand in hand, both prevention and intervention. And we're not yet doing a great job at that. The slide I have here shows you some research we did on Medicaid coverage of obesity treatments. This was initially done in 2010, and we're updating it right now. It'll be published sometime in the next 6 months. At this point, 34 states have strong evidence for non-coverage or explicit exclusion of obesity medications, and many others have no mention of obesity medications in their Medicaid brochures, so they very well may have non-coverage as well. And this is a big problem. We have a number of very valuable medication treatments for obesity, when used the right way in the right patient, can make a huge difference in their lives, in their obesity levels, in their levels of obesity-related chronic diseases like diabetes and high blood pressure. And yet most people don't have access to these potentially helpful treatments. If we think about other similar health conditions like chronic high blood pressure or chronic high cholesterol, there's many options for treating those. And yet when it comes to obesity, very few people have access to those. So that's something that's really quite important that we move forward toward, again, for those people who are already affected and for whom such treatments might be helpful. In terms of bariatric surgery, we've actually made quite a lot of progress in terms of Medicare coverage for bariatric surgery. In terms of Medicaid, there are still a number of holdouts of states that either have no formal coverage or explicitly exclude bariatric surgery as a covered service. And again, that would be like excluding heart disease for patients that have, heart surgery for patients that have advanced heart disease. These are treatments that should be covered, again, for the right patients at the right times in the right amounts. And if we could go to the next slide, please. The reason this is particularly important is that with the ACA now, we're seeing, unfortunately, quite a number of states that have explicit exclusions in their proposed EHB benchmark plans. I just put a few here. Missouri, as you see, excludes bariatric surgery and treatment of any or coverage of any complication related to bariatric surgery. Kansas as well has explicit exclusions of medical management of obesity, medications, counseling, and so forth, even though, again, we have good evidence that these things can be incredibly helpful. Where I'm from, Washington, D.C., there's a number of exclusions as well. In Maryland, I live in Maryland. I work in Washington, D.C. Thankfully, there's none in the proposed benchmark plans, no explicit exclusions in Maryland. This is important for a number of reasons. Next slide, please. First of all, obesity is a chronic disease. You could argue with the word disease if you like. We could call it a chronic condition. That doesn't really matter to me. At this point, though, the American Medical Association, as many of you have already heard, I'm sure, has declared obesity a disease. But for many years before this, many other of the leading healthcare and medical organizations have already made that declaration, including the World Health Association, the FDA and the NIH, and a number of other organizations. It's hard when you study up on obesity. It's hard to argue against it being a chronic disease. And while chronic disease identification and treatment is an essential health benefit in the ACA, obesity doesn't appear to be, at this point, well covered in the state benchmark plans. And I think that is both a huge strategic problem and also an ethical problem. The other reason it's problematic is that obesity treatments work, and I'm going to show you a little bit about that in just a second. We have lots of treatments for obesity that can make a big difference, both in people's weights, but especially in terms of their health, in terms of their feeling and functioning. And so to not have access to these treatments for appropriate patients is a real shame. And then finally, the potential savings are enormous, and so it would be a real shame again to not have access to treatment for appropriate patients when so much savings is possible, and I'll show you a slide on that as well. If we could go to the next slide, you see here a melange of a number of different obesity treatments. This is by no means comprehensive. There are many other treatments that are helpful, but I just wanted to give a sense of how many treatments are out there that can make a big difference in people's lives. This includes behavioral counseling and behavioral strategies, and I show some of them up at the top in the top pieces of the slide. It includes intensive medical interventions, which have been shown to lead to more than 10% of body weight loss in a good number of patients, including medications for weight management, including the newly FDA-approved lorcaserin and the newly FDA-approved Qsymia medications. Lorcaserin is Belviq. They can lead to, again, about a 10% decrease in body weight, which has been shown to make a huge difference in people's health, feeling, and functioning. And then at the bottom right, I show you some curves of different bariatric surgeries on weight. And bariatric surgery, again, in the right patient can lead to a really significant amount of weight loss, and has also been shown to lead to decreases in mortality rates in patients overall. So there's a lot more research we need to do when it comes to obesity treatments, and there's a lot more research we need to do to bring more treatment options to the table, just like we have when it comes to other chronic diseases. But again, it would be a real shame to not have access to treatments like these for people that could benefit from them. And next slide, please. There was a study published a few years ago, and it was popularized very significantly this past year in Trust for America's Health F as in Fat report that they put out every year. And they showed that we could have a healthcare cost savings of $29 billion in just the next 5 years with just a 5% reduction in average weight. A 5% reduction in weight is something that all of these treatments that I put up on the last slide, all of them lead to an average of at least 5% weight loss. And this could make a humongous difference economically if we could get those treatments out to the people that need them. When you extrapolate those curves out even further, I believe the numbers were about a $65 billion healthcare cost savings at 10 years and significantly more thereafter in the coming years. So, this is a real opportunity to make a dent in the cost curve of our healthcare costs. Next slide, please. So I'll just leave you with two quick slides. One of the hats that I wear is the director of the Stop Obesity Alliance, which is a nonprofit George Washington University-based policy organization focused on obesity prevention and treatment. We work to advance the conversation around obesity. We bring together key stakeholders to work together to promote innovation and strategically move the needle on obesity and obesity-related health problems, and we conduct research on obesity policy and treatments. And I won't go through the whole list here, but I wanted to offer this as a resource to you all. We've been working in this area for years, and we've made a lot of progress that has helped push the needle forward nationally. We've done some state and local work as well, and we have a wealth of resources that might be valuable to you, and I put myself forward as a resource who might be valuable to you as well. And I want you to feel free to go to our website, which is the www.stopobesityalliance.org. And either sign up to be a member. It's free and may be very helpful, or just peruse through the information that's there, and hopefully it will be of value to you in your work. And next slide, please. This is the last one. One of the things we do as part of the Stop Obesity Alliance is we release a quarterly bulletin called Weight in the States, where we put out a bunch of research that's directly relevant to states around obesity and obesity policy. For example, our most recent one, we examine Medicaid coverage of obesity services, which of course is important to you all because Medicaid finances a significant portion of the $100 billion in direct medical costs attributed to obesity. So this is a free thing that you can have emailed to you. You can go onto our website to sign up if you like, and hopefully it will also offer some more hints and helpful resources for you. So I'll stop there, and I put my email on the first slide. Please don't hesitate to email me for anything you need, and thanks to all of you for coming together on this really important national and local health issue, and I'm very confident that we're going to continue to make big strides in addressing obesity in the coming years. So thanks.